Okay, we are good to go. All right. Okay, let's get started. Welcome, everyone. Thank you for making the time in your busy day, especially the holiday season, to join with us and focus on how we can build each other up and stay safe as a community, as a state, and for those watching out of state, as just a larger community at large in general. I'm Noel Sanders, she, her. I'm a senior community organizer at the Boston Center for Independent Living. And I just wanted to go over our demands for this conference before we get into our speaker list. Our group is calling for first, safe and accessible healthcare. The Massachusetts Department of Public Health needs to recommend universal masking in all healthcare facilities, including dental clinics and facilities, and pre-procedure COVID-19 screening testing for all patients on admission and prior to outpatient elective procedures. Second, free access to the tools to prevent and treat COVID-19, which DPH and Governor Healy must make PCR and rapid testing free and accessible to Mass residents in order for them to do that. And by reviving the state-run Pixel Lab at-home test distribution kit program, along with through using community health centers, we can supply high-quality respirators to the public, along with N95s, not just surgical masks. Our third demand, we need to communicate in public and mass the risks of long COVID, educate people about the risks of long COVID, the prevalence of long COVID, the importance of masks, vaccines, all of these used in tandem as protection measures, and the risks of repeat COVID infections, which is happening to so many people that we know and is forecasted to happen as we head into the holidays, the time of travel. Our last demand, number 4, but not least, defend disability rights. The DPH and the Massachusetts Health and Hospitals Association, MHHA, should issue formal guidelines to all healthcare institutions in the state to uphold the principles of the Americans with Disability Act, known as the ADA, and Section 504 of the Rehabilitation Act by urging healthcare facilities and other public institutions to meet requests for access to universally masked public spaces. And I know I just ran through those. We will get into all of those in detail, but just know institutions have issued no guarantees to protect the rights of disabled patients to request that their providers mask. And instead, they're forced to basically just rely on the goodwill of staff, let alone hoping that they have surgical masks, even better, N95s, respirators. Even KN95s would work in a lot of these settings much better than surgical masking. So without further ado, our press speaker list is, I will go just through the list and then introduce them each as they come. Dr. Ted Pack, PhD Infectious Disease Fellow at Boston Hospital. Colin Killick, Executive Director of the Disability Policy Consortium. David Alpern, MD, physician based in Northampton, Mass. And Lara Jirmanus, MD and PH, primary care physician and instructor at Harvard Medical School. And I'd also like to add onto that list, Jayda Jones, who is a local disability rights advocate and PH as well. We'll start with Lara, who also has some slides. Lara, I will pass the floor over to you.
Thank you so much for that wonderful introduction. Can everyone see my slides? Hopefully.
All good.
Right. Great. So we'll be going through some information about, components, a recipe for safe hospitals this holiday season. So first of all, it's always important to remind folks that COVID is airborne, meaning that it spreads through the air like smoke. So it's not sufficient, to only wear a mask. Masks protect you, but you can even become infected by someone after they've left the room. And because it floats around in the air like smoke, it's really distance is not sufficient to protect you. So proper ventilation and mask use reduces exposure. And actually, over 50% of COVID-19 transmission still happens without symptoms or before people develop symptoms, which means people can infect each other without knowing it. And that is a major reason why it is helpful for people, especially during periods of high transmission, for everybody to be masked to protect everyone. Universal masking, as opposed to one-way masking, makes a huge difference. This data still has not changed, except that with more and more contagious variants, it becomes even more likely for people to be infected in shorter periods of time. But with the Delta variant back in 2021, 2 minutes of exposure of two people about 3 meters apart, or about 10 feet apart, there's a 90% risk of a susceptible person being infected by an infectious person. That risk drops to 0.8% after 2 minutes if the susceptible person is wearing a KN95. But after an hour of being in the same room with an infectious person, the risk goes to 20%. On the other hand, when everybody is masked, the risk is cut substantially, and so down to 0.4%. I think when we think about this, it's really important for us to think about what are the goals of our health systems in general. Many of us, seen the triple aim or the quadruple aim, which has been put out for years by the Institute for Health Improvement. And, thinking about what does it mean to push for better outcomes, lower costs, improve provider experience, and improve patient experience? What does this mean when we're denying patients' most basic requests not to catch COVID or another respiratory illness while they're at the doctor? And I want to just talk a little bit about what it looks like when you take a different approach to masking in healthcare. At the health institution where I've been working since May, our health institution made a decision to be patient-centered, offering patients the option to ask their care team to mask. A lot of other health institutions have required health workers and patients to provide medical documentation should they want their care team to mask. That can be very intimidating for people. I've seen people not be able to provide that documentation or struggle trying to get that documentation from their doctors. And the question is, why are we even doing this? It makes a lot of sense also to be masking seasonally to make care safer during periods of higher respiratory virus transmission. This is something that the CDC mentioned, was an option for healthcare systems. And then of course there is the general opinion that we have heard from a number of different experts out there that masking should just be added as another standard precaution in healthcare. And so, I think that some of us today will be commenting on whether anti-mask policies in healthcare are well supported by science and medical ethics. As the numbers go up, we see our wastewater data again trending upward. So this is data from the North system in MWRA wastewater data, and you can see it's starting to trend upward again after an initial spike after school started in the fall. And we anticipate that our respiratory viruses will go up, as they always do every year, especially during this season. The South system signal looks the same. And then this is the national data on COVID hospitalizations. As you can see, the numbers of COVID hospitalizations again starting to increase. So everything is pointing at a surge. Also, the public is increasingly concerned about COVID outbreaks in their area. So you can see, we had a higher numbers of the public less concerned, but actually now about 50% of the public is concerned about a local COVID outbreak in their area. And this is data as of the 18th of November. And they probably should be concerned. Even the New York Times last week pointed out that increasing numbers of Americans say that they are in a cognitive fog. And those numbers are increasing, especially among adults in their 20s, 30s, and 40s. Researchers are pointing to long COVID as a major cause of this problem. This is really serious. Taking a look at the percentages of working age people who said they had a difficulty with remembering, concentrating, or making decisions is rising higher than ever before since we actually started collecting this data. So right now, 1.5 million more US residents between ages 18 to 64 report being disabled than ever before. And most of these problems, again, are occurring among young adults, ages 18 to 44. So here is the percentage of Americans saying they had a serious difficulty remembering and making decisions. And you can see for the 18 to 44 population, the increases are really quite striking and actually starting to approach the levels of patients in the older age group, ages 45 to 64. A reminder that long COVID may impact between 10 to 70% of people who are infected. Long COVID is a cluster of syndromes which can affect organs throughout the entire body. I talk about this to patients, and some of them are unaware that long COVID even existed, but it can impact the nervous system. It can impact and cause dementia, cognitive problems, problems sleeping. It can cause also blood clots, chest pain, heart problems, kidney problems. It can also increase the risk of diabetes, among others. Just looking at the Massachusetts residents alone, every couple of weeks, updated census data demonstrates to us the reports from residents of the state of Massachusetts and around the country how many people have experienced COVID. Of all Massachusetts residents, 16% right now report having experienced long COVID since the beginning of the pandemic. When you calculate that in terms of raw numbers of people, 915,000 people in this state alone have been impacted by COVID. About 274,000 report current limitations from it. And then right now, over 100,000 are actually reporting significant limitations, which could be interpreted as disability from COVID, from long COVID. So in sum, I'm just going to sum up as Noel had already stated, the recommendations that this group has today for a safe and healthy holiday season. Number one being universal masking and pre-admission COVID screening in all healthcare facilities. Free access to the tools to prevent and treat COVID, making sure we all have access to the PCR and rapid testing for everybody, and also distributing high quality respirators to the public and free access to COVID vaccines and antivirals. Communicating the risks of long COVID to the public, and defending disability rights. We're really calling on DPH and the Massachusetts Hospitals Association to issue formal guidance to health facilities and other public institutions to make sure that patients have access to universally masked public spaces so that everybody can be able to access healthcare, education, and other vital resources without being exposed to COVID. Thank you.
Thank you so much, Lara. I really want to highlight that piece of just knowing that 50% of the public, that means 1 in 2 people, is really concerned about contracting COVID this season, getting COVID, and people just want to know what to do to protect themselves and to have the information they need to stay safe. I think often we hear messaging that, the pandemic is over and there's pressure for it to be over, but at the same time, so many people around us are concerned and just don't know how to externalize that or what to do about that. So thank you so much for that really strong data-driven presentation. I'd like to introduce our next speaker, Jayda Jones, MPH. She's also a disability rights advocate. Take it away, Jayda. Thank you so much.
Thank you, Noel. Hi, everyone, and thank you so much for being here with us today. I just wanted to highlight how healthcare facilities have failed to provide safe and accessible space for individuals who are disabled, immunocompromised, or chronically ill, and nor have approved reasonable accommodation requests for healthcare workers to wear N95s. So first, I just wanted to indicate that individuals don't have sufficient information to understand or exercise their rights to request modifications from their hospital-based providers, nor is this process clearly communicated to patients. MGB specifically states that their policies are based on public health guidance and infection control experts affirming that, quote, universal masking is no longer medically necessary to protect patients from COVID-19, and their commitment to, quote, ensuring that patients can access medical care is in a safe and appropriate manner. And if this were accurate, we would not see COVID-19 outbreaks within hospitals and long-term care facilities after the public health emergency ended. With the removal of mask mandates and of admission, repeat admission, and serial admission testing for asymptomatic patients in healthcare facilities as of May 12th, not only are we unable to identify asymptomatic or pre-symptomatic cases among inpatients, but we're also unable to control transmission when several are unmasked. The information hospitals are providing are not scientifically based and continue to be harmful for individuals who rely on their healthcare facilities to provide safe and accessible healthcare. Patients are relying on their healthcare providers' policies and therefore are becoming misinformed and at an increased risk of becoming infected with COVID. Second, I wanted to share that people with disabilities are being discouraged from asking for masking or related COVID measures as part of an individualized accommodation modification request, or told that these requests are no longer valid or medically necessary after May 11th. NGB also indicated that patients can ask, but providers determine when and if masking in a particular situation is clinically necessary. I just wanted to state in our co-work sessions that we have to help folks with submitting reasonable accommodations requests. Most have shared that they've been denied reasonable accommodations and are not considering their disability vulnerable enough to comply with the requests. And so this leads to some people with disabilities delaying or foregoing medical care and treatment since the end of the public health emergency because they've not been provided with modifications that would make it safe to continue accessing the hospital setting. And several have been denied from their providers for following modifications outlined in the reasonable accommodation requests they submitted, and are left to delay services and find other providers that will provide safe and accessible services. In addition, many have experienced providers minimizing their concerns or diluting their health risks, once again, to anxiety-related fear of being exposed or infected with COVID, instead of actually acknowledging the scientific based risk factors. And not only does this lead to the delay of services as patients are being individually responsible for finding healthcare providers who abide by their accommodations requests, but this also continues to increase medical distrust, which has led to poorer health outcomes already. And since the end of the public health emergency, there have been reports of COVID-19 outbreaks at hospitals and long-term care facility among patients and staff. Patients should not have to consider their likelihood of becoming exposed or infected with a hospital-acquired infection. And if so, we know that it's due to the lack of protections that we have in place to control infectious disease transmission. And even when left to individual advocacy for their health, they are literally being denied mechanisms that could reasonably be applied in a healthcare setting. Patients have the right to receive safe and accessible healthcare, and the current individualized approach to an issue that can only be resolved if there is a collective effort to mitigate transmission will continue to burden those most marginalized. Patients with disabilities are having to choose between delaying care so they avoid being infected with COVID at a hospital or continuing services and increasing risk of being infected and severely harmed by COVID. The end of the public health emergency does not equate to an end of their continued high risk of severe disability or death from COVID. Healthcare facilities can alter and implement policies to ensure the rights of patients with safe and accessible healthcare. Thank you.
Thank you so much, Jayda. And if anyone would like to reach out to Jayda also to get a little bit more information on how you can work with your provider to request those accommodations, we would be happy to help you with that process as well. Feel free to reach out to us after this conference. Our next speaker is Dr. David Alpern. He's going to be speaking with us. Dr. Alpern has, my screen just had a little tech glitch. Dr. Alpern received his undergraduate degree from Harvard College, then attended med school at Case Western Reserve University. He did 3 years of basic research in cell biology at the Cleveland Clinic, and then attended his internal medicine residency at Mount Sinai Medical Center in Cleveland. And he has practiced general internal medicine from 1985 through his relatively recent retirement in mid-2022. He's still very active in his community, and thank you so much for being with us, Dr. Alpern. Please feel free to share a little more on how we can stay safe.
Thank you. Thank you for joining us today as we advocate for a crucial cause, the reinstatement of universal and high-quality face masking in healthcare settings. Having spent 37 years as a board-certified internist, I've witnessed the profound and lasting effects of COVID-19 and I believe it is our responsibility to take action to protect patients, healthcare staff, and visitors. The United States EPA highlighted, actually I saw this online in a recent date, actually highlights that COVID-19 spreads through airborne particles and droplets. These particles can linger in the air for hours, moving through a room and accumulating. Transmission can occur at distances greater than 6 feet, and the risk of infection is particularly high indoors, with symptoms of COVID-19 often indistinguishable from the common cold. And the unreliability of home tests, healthcare staff who may go to work with symptoms become potential spreaders. And we do know that many healthcare providers will go to work when there's symptoms. I used to go to work when I had a cold, before COVID. I mean, why not? Now, of course, with COVID, if people aren't aware of the potential or they aren't aware they have COVID, that definitely could make a big impact. What's more concerning, as was mentioned earlier, is that over 50% of COVID transmission occurs before symptoms develop, with another 40% of cases being asymptomatic. This really means that anyone, patients, visitors, or staff, can potentially transmit the virus. The absence of N95 masks in healthcare settings inevitably leads to increased COVID transmission, which, by the way, can contribute to our worsening healthcare workforce crisis. Terminating infection controls, especially in healthcare facilities, puts individuals with physical and mental disabilities at even greater risk, as we just heard. The American with Disabilities Act safeguards their rights. And considering that age is a significant risk factor for severe COVID-19 outcomes, the elderly and medical units are particularly vulnerable. Many of these patients may have had a COVID infection at least once, say prior to their current admission. A recent study showed that counterintuitively, having had a case of COVID from the Omicron variant, in this study, residents of long-term care and retirement homes actually had an increased risk of reinfection with Omicron. Presumably, this would apply to elderly patients in the hospitals as well. And of special concern is the fact that hospital-acquired COVID-19 carries a much higher mortality rate compared to community-acquired cases. About 5 to 10% of people who get COVID in the hospital die. I'd like to now talk about long COVID. It's important to know that people of all ages can develop debilitating long COVID. But long COVID is a particular concern among older people. And among a number of studies have suggested the risk of developing long COVID actually increases with age. And long COVID is even more likely to develop after repeat infections. The CDC estimates as many as 1 in 5 Americans are now dealing with long COVID. Vaccination has been shown to reduce the risk of long COVID, but does not eliminate the risk. So, and even mild or asymptomatic COVID-19 infections can result in over 200 long-term health issues affecting every organ in the body and leading to an elevated risk of heart attacks, strokes, brain damage, and weakened immune systems, which can predispose one to getting more frequent or severe bacterial, viral, or fungal infections. Healthcare facilities, with their primary focus on patient and employee health and safety, must apply the precautionary principle and honor the Hippocratic Oath. Reinstating universal maskings is imperative to prevent the spread of aerosol viruses, particularly for our vulnerable older population. Mandatory COVID-19 testing for incoming patients is crucial, and universal precautions, including high-quality masking, will offer protection against healthcare-associated spread in future pandemics. So in conclusion, let's prioritize the well-being of all by advocating for the reinstatement of high-quality universal face masking in healthcare settings, the simple yet effective measure to safeguard the health of our communities. Thank you.
Thank you so much, David. Yes, we want everyone to be safe, and disability rights protect everyone. It's disability rights in the short term, that protects everyone in the long term, like with so many wins, even things we don't often think of, like curb cuts and sidewalks. So thank you so much for highlighting that. Moving on, we have Colin Killick, Executive Director of the Disability Policy Consortium.
Thank you so much. I wanted to really just echo a lot of the comments that were made already, particularly by Jayda. For those unfamiliar, our organization, Disability Policy Consortium, is Massachusetts' primary statewide disability rights advocacy and research organization. And had been saying since the initial abandoning of universal masking in hospitals that this was going to pose a serious risk to people with disabilities, and that we predicted at the time that hospitals would not adopt sufficient, robust mechanisms for disabled patients to be able to request masking ahead of time as an accommodation, despite being legally obligated to do so. And both of those have borne out. Disabled patients have been exposed in hospitals. Hospitals have, by and large, not put sufficient mechanisms in place, particularly to allow disabled patients to request masks ahead of time. They've put onerous requirements in place, showing people to provide documentation before having masking in many facilities. And the results have been dire. This is an access issue. This is a civil rights and equity issue, because a lot of people with disabilities do not have the choice in how often they go to the hospital. They have to go on a regular basis to get care for chronic conditions. And every one of those visits becomes a roll of the dice. And as that data that Lara showed demonstrates, that the odds on that dice roll are a hell of a lot worse when the people providing the care are not masked, because folks from our community are often in medical facilities for hours at a time getting treatment. And also the point about other kinds of respiratory illnesses, especially this time of year, is well taken. My family live in Arizona, and my stepmother about a month ago went into the hospital for diagnostic testing to determine if she was having a cancer recurrence, and within 2 weeks was dead of hospital-acquired pneumonia. So there are lives at stake. And the answer, as we've been saying all along, when we said that it was not the time to withdraw masking in hospitals, people, we got pushback saying, well, then when will it be? And just as there is never going to be a good time to stop wearing gloves in hospitals, I can't understand why we oughtn't just continue using a basic, simple intervention that results in individuals, patients being safer and saved lives, right? Are there edge cases where it makes sense for masks to be removed? Sure, but the default should be mask on. And if those cases need to be accommodated, they can, rather than requiring people with disabilities to jump through hoops to reduce the odds that they will acquire debilitating and potentially deadly illnesses. It's not fair, it's not just, it is burdening a community that is already systematically marginalized, systematically impoverished, systematically at risk of violence and death, with further burdens. Our community is already made up about 2/3 of those killed by COVID. Let's not needlessly sacrifice any more. Thank you.
Thank you so much, Colin. And also I want to extend on behalf of all of the panelists our condolences for your loss as well. Thank you so much for still being here and for continuing the fight. I'd like to also just highlight that important point where we use gloves as a basic element of infection control prevention. And this is just very much the same thing in the logic of keeping patients safe while they're in hospital and clinic for procedures. Going to our last speaker, Dr. Ted Pack. I'd like to introduce him. He is an MD at Boston Hospital, PhD infectious disease fellow. Thank you so much for being with us, Ted.
Hi, and thank you. I just wanted to emphasize some points here about why, in Dr. Jirmanus' slide, why we continue to advocate for safe and accessible healthcare with regard to resuming universal masking and universal admission screening, and some of the science behind that. By way of background, I currently do research in hospital epidemiology and work with some of the people that develop evidence for these measures. First of all, regarding masking and admission screening, it would be one thing to consider that they are largely ending, with other robust protections in place. But if we zoom out for a second, we can see that a lot of the other measures we relied on during the COVID pandemic and continue to need really have disappeared as well. And I'm talking about free community testing, booster rates, mandates for vaccines, routine symptom screening, physical distancing. So the whole idea that we can peel off layers one by one is not even what's occurring, because there are very, very few layers left to decrease the risk of COVID among people in the healthcare setting based on everything else that is not really available anymore. So I'm going to talk a little bit more about universal admission screening and masking in particular, and then end on the trend that is occurring now for even using N95s in a healthcare setting around known COVID patients. Next slide. So to start, I just want to give 5 reasons, previous slide, please. Thanks. That there are 5 main reasons that I and some colleagues recently outlined in a viewpoint about why universal testing of patients on entry to the hospital should continue, and they really apply to masking as well. First of all, hospital-acquired COVID remains common, and it has been systematically underreported and underappreciated, particularly in the United States, where our mechanisms to collect these data are in large part absent. In other countries with more robust mechanisms like the UK, we have seen tens of thousands of patients, and we're talking about rates of like 1 in 7 patients during the waves of COVID getting their COVID while they're in the hospital, which are staggering numbers when you start to consider how many of those patients then experienced severe outcomes like death or disability. In the United States, because of how we collect our data, largely we only hear about these outbreaks when they become so large that they cannot be hidden. And for instance, there were outbreaks in the Boston area that did come out in the Boston Globe and other media outlets. And I have to credit at least the leaders that investigate those outbreaks for at least putting a lot of evidence out there about what really happened in those scenarios. For instance, in doing genome sequencing on that Brigham Hospital outbreak, it's discovered that infections did occur between workers and patients, even with both parties wearing surgical masks. So to imagine that, you know, without that layer of protection, what would happen? It's sort of simple to draw the outcomes and see what the value of better masking is in the hospital setting, which was argued in those investigations. Secondly, the point has been made many times already on this call, but pre-symptomatic and asymptomatic COVID is the most common kind of COVID that is being transmitted. Over 50% of patients will infect somebody else before they have symptoms. Next slide. Point 3 is that, as has been stated, when you go to the hospital, and many patients don't have a choice about going to the hospital, they need healthcare, and that is the place in their community where they are going to receive it. You often don't determine the circumstances in which you are admitted or housed at the hospital during your stay. And as we all know, shared patient rooms are very common in Boston and many other cities. And it is found also in a study at Brigham that if a patient is sharing a room with somebody that is unknown to have COVID and later is found to have COVID, the risk of transmission is high as 39%. That's an incredibly high risk. And it's a simple inference from that if we aren't testing all patients on entry to the hospital as to whether they have COVID, and if many of them have asymptomatic infections, so you wouldn't know to test them without universal testing, that the rates of people getting COVID while in the hospital are going to increase. Fourth point is regarding the harms of hospital-acquired COVID. It has been stated by people that argue about this problem, who I don't disagree with, that it's not as much of a problem anymore. In other words, that the changes and variants in COVID have somehow decreased this risk. However, as we all know, people that are hospitalized are at particularly high risk of severe outcomes. It is a concentrated population for those who are most vulnerable. And if we look at countries that do have good data on this, again, which is not the United States, because we do not collect good data on this, but in, for instance, Germany, Singapore, nationwide data from Wales, a country in the UK, we are seeing crude mortality rates of 11 to 13% for Omicron variants. So any kind of argument that Omicron is not a threat somehow in the hospital setting, I just do not find credible based on these data. Next slide, please. And then the fifth argument is simply the ethical responsibility, which I feel has often gotten lost in these benefit risk arguments among people in hospital epidemiology. It's a simple truth to me that hospitals are supposed to prevent harm to their patients above and beyond the protections that we expect in other public settings. As has been said on this call, many people do not have a choice about going to the hospital. We often go to the hospital when we are in a time of great need. Sometimes we aren't able to advocate for ourselves because of how sick we are. And to expect that patients need to become infection control experts and teach each of their providers about why they need to mask around them is just a complete inversion of what I would expect, in a healthcare setting where the simple principle of do no harm would state that we are cautious and look out for patients rather than forcing them to invert the entire system that we've had. Most of the people here listed as being high risk for COVID are exactly the kind of patients that we see in the hospital very frequently. Older patients, immunocompromised patients who are on medications, and these are common medications, relatively speaking, among hospitalized patients, like chemotherapy or medications after a transplant, medications for autoimmune conditions, all of which increase the risk of COVID. And at the same time, our typical methods of protecting against COVID, like Evusheld was one of these measures, have no longer become effective. So over time, I think this problem has become more severe about the risk to people coming in the hospital that get COVID while they're in the hospital. Next slide, please. Two more points that I'll make specifically about testing, which is something I hope we still remember, even though masking is currently another area in which we're falling behind on. First of all, in studies that have released data about it, when universal testing was ended in, say, Scotland and England, rates of hospital onset COVID jumped dramatically in the 26 to 41% range. And that's adjusting for rates of COVID in the community. The final point I'd make about testing is that concerns over its cost, I think, are largely blown out of proportion compared to the incredible costs of COVID and exposing patients to COVID in the hospital. Tests contribute, according to one study, a cost of about $55 per patient. Compared to the cost of the hospital admission, that is incredibly small. We charge patients about that much for one pair of non-sterile gloves, according to some reviews of Charge Masters, and not so long ago. So I disagree with the idea that the costs of universal admission testing cannot be mitigated using algorithms and other approaches for discontinuing testing and controlling false positives that have been done at many of the hospital systems in Boston already. Next slide. I do want to add that this is not a controversial view among hospital epidemiologists that we should actually continue to be masking in hospitals. There are prominent leaders in hospital epidemiology, including, for instance, here's David Weber, who is on HICPAC, and other folks that are very influential and in the societies that infection control experts participate in. Next slide. However, there are several HICPAC members that have openly stated their disagreement with the importance of masking in healthcare settings at this point in the pandemic. And their arguments I have found largely unconvincing that the major harms cited of, say, masking are impeded communication, increased cognitive load, and other psychosocial effects, like not being able to engender trust. But I would think that the most that these pale in comparison to the mortality, the disability, the incredible risk to patients, the horrendous stories that I've heard from my own patients, I've seen in person, as to what happens when they do get COVID in a hospital setting. I just don't understand these arguments that have not really, I think, weighed the continued harm that is occurring. Next slide. So just to focus on one last thing, which is perhaps one of the remaining special or protections that we have regarding spreading COVID in the hospital, which is using N95s with COVID positive patients. Next slide. So some of you may have heard about HICPAC, which is, I should have explained, a committee formed by CDC that promotes guidance about certain hospital infection control measures or other healthcare infection control practices, and an updating guidance which hasn't been updated for nearly 2 decades. Some of the draft guidance, in my view, is going to weaken protections in the hospital simply by, at least how it's being formulated here, not clearly mandating N95s for use with known COVID positive patients, which is something I have not seen myself yet in the setting, despite all of these other measures disappearing. N95s are generally considered an important thing to use in the hospital, given what we know. Even with very good surgical masking by both parties, we have demonstrated in, say, the Brigham outbreak and other settings that transmission can and does occur. So why not use a better mask when you know the patient has COVID? Would you really want, your healthcare provider to walk out of a room where somebody else had COVID and just walk in and talk to you without wearing an N95? I mean, it's surprising to me that the guidance would be formulated in this way. And granted, it is not talking about COVID specifically in the way it's written, but the kind of language that's being used here, like endemic, some degree of immunity, are exactly the kind of words that proponents of weakening infection control measures have used to describe COVID already. So I really worry that this is a trend that we need to continue to fight against. And there's so many arguments against weakening these protections for patients in healthcare settings. We simply need to make sure they are heard, widely understood, and continue to let hospital leaders know that it's unacceptable to do anything otherwise. Thank you.
Thank you so much, Dr. Pak. Thank you also for everyone who's continued to stay on. I just want to oh, perfect. I'm spotlighted. I just want to repeat, go over our demands before we head out. And then I'm not actually sure if there is a time for questions. Someone correct me if there is not, but I know that we do have a Q&A feature. And I know after I read these demands, we can check and see if anyone has submitted any questions, anything we can support with or help with. Yes, it sounds like we will have 5 to 10 minutes for questions. So please have those ready. If you raise your hand, the host will have an opportunity to unmute you. Yes, just back to our core 4 demands: safe and accessible healthcare, free access to the tools to prevent and treat COVID-19, communicate risks of long COVID. And to clarify, that is a public health messaging mandate for people to receive that information widely, and to defend disability rights in this entire process, centering them, fighting for them front and center by giving people with disabilities the support when they ask for those accommodations that they're guaranteed by the ADA, the Americans with Disabilities Act. Just going into a little bit more detail: safe and accessible healthcare. The Massachusetts Department of Public Health, DPH, must recommend universal masking in all healthcare facilities, including dental clinics, and pre-procedure COVID-19 screening testing for all patients on admission and prior to their outpatient elective procedures. free access to the tools to prevent and treat COVID-19. We're calling on DPH and Governor Healy to make PCR and rapid testing free and accessible to Mass residents, largely by reviving the state-run Pixel Lab at Home Test Kit distribution program, and by continuing to support community health centers, offering these tests and supplying high-quality respirators to the public. Communicating the risks of long COVID, educate the public about those risks as we've covered, especially the importance of masks and using masks in tandem with getting vaccinated, as well as the risks of repeat COVID infections, recurring COVID 2, 3, 4, potentially more times. And again, to reiterate that element of disability rights, we're calling on the DPH and the Massachusetts Health and Hospitals Association to issue formal guidance to all healthcare institutions in the state to uphold the principles of the ADA, the Americans with Disabilities Act, and Section 504 of the Rehabilitation Act by urging healthcare facilities and other public institutions to meet requests for access to universally masked public spaces from everyone, but especially from our consumers. And this also covers nursing homes, facilities where people are staying in more long-term settings. We also need protection in those settings as in congregate spaces. We know there is high precedent and high documentation of transmission. Going into our question section, I'm going to just click on them. Looks like we have 2. I'll just read these out. Feel free to add more into this Q&A section if you'd like. Not just COVID, someone just commented, not just COVID, but RSV, H1N1, and pneumonia. Yes, that's more of a comment than a question. I love Laura's response. This is absolutely true. In fact, research demonstrates that during periods of universal masking, rates of hospital-acquired infections with other respiratory viruses have also substantially dropped. And this comes to mind, we also remember as we were masking heavily in 2020 and going into 2021, we saw fewer instances of flu and several other diseases, including the common cold, when people were using masking. Masking kind of was instituted to protect us from COVID, but has so many other spillover benefits as well. Next question, will the recording of this press conference be sent out? Yes, we'll share with participants. It will be on our website, the MCHE website. I know there's been discussion about it being on YouTube. I'm not sure about that, but feel free to follow up with me. And I just want to open this up to our panelists. Would anyone like to just comment a little bit more, maybe voice questions people have asked you? Or make closing statements, and I'll ask everyone also, if possible, to come back on camera. As a friend of mine says, don't all speak at once.
I think I just want to comment, make one comment that I sort of made in the beginning, which is that for since May, my health system, the health system which employs me, but which I will clearly state I do not speak on behalf of, but I do want to mention it because Cambridge Health Alliance had a policy of allowing patients to request their care team to mask. It's a great idea. It's very patient-centered. It is not perfect because, of course, probably the most likely place that somebody is going to be exposed to COVID is in a shared waiting area. But it just makes sense, and it just doesn't actually make any sense to do anything but that. So I'm just at a loss and trying to understand, is this an ideological point of view of health systems that they have simply decided that they must decide for patients what level of infection control is right for them? Nothing else really makes sense. The patient-centered thing to do is to do what patients are asking you to do, or at least to give them the option to do it, rather than to be denying these disability accommodations requests left and right. With regard to these comments in the chat, absolutely, there's definitely data that demonstrates that during the periods of universal masking earlier in the pandemic, not only did it save lives due to COVID, but it also prevented many respiratory infections. Because we don't actually collect data at all in this country anymore, regarding hospital-acquired COVID, that's no longer something that hospitals are required to report to the CDC. It's very difficult to assess, but I will say, of course, extensive research on long COVID demonstrates that people who had been hospitalized with COVID were significantly more likely to develop long COVID. I think the lack of data about hospital-acquired COVID in this country makes it difficult to comment on the specifics of rates of long COVID after hospital-acquired infection.
Thank you so much, Lara. Even just on that, a little follow-up to that point of why maybe a policy like that is ended. I've noticed just as a community organizer, a lot of the logic I hear people talk about in kind of combat to the arguments of masking is not wanting to live in fear or language like that, or just this idea that, you know, mass panic will ensue if people see a ton of masks or things like that in indoor settings especially. And I think it's just so important to highlight that these are patient-centric, consumer-centric ideas, and we're not coming from a place of fear. We're coming from a place of community dedication, self-care, but also care for those around us. This is a simple preventative measure that is, you know, relatively low cost, can be even lower cost when subsidized and supported by our public institutions and our public centers of government. But we are advocating protection so that we can keep each other safe. And it's just like, you know, we have hand sanitizer. When we go into restaurants, we expect to see people cooking our food with gloves. It's back to that argument that we heard earlier, especially from Colin. These are measures that are just safeguards. They're not meant to elicit fear. They're not meant to be a harbinger of a time of panic for the rest of our lives forever. They're just simple measures that are effective, that work, that we can institute with pretty much almost complete ease and protect each other. So I think that's really important to highlight. And then also, when it comes to disability rights, we're trying to create systems that actually support us. And we know that especially with long COVID, we're in an unprecedented mass disabling event. We're seeing so many people incurring new disabilities. And especially for me as a disability rights advocate, our goal is to, in a world where we know that our systems are inherently ableist, they don't support us, we want to make sure that we have healthcare systems that care for us, that support us, and where possible, where we can do the most that we can to keep our communities healthy and safe and supported. And we're calling on our health institutions to do these relatively low cost and easy things that they can do to keep us safe, and especially to incur fewer bad outcomes within the institutions as well. Does anyone else want to say maybe closing comments or voice maybe things you've heard? I know, Jayda, you've been doing a lot of community-facing work as well. Open call for anyone to unmute. All right, no takers. Okay, we can move to closing comments. I think it'd be great if maybe every speaker could offer just a line or two in closing, but if not, I'd happily pass the mantle over to Lara.
All right. Well, thanks everybody for joining us today. We've heard a lot of data about the value of masks and tests in healthcare, as well as some clear evidence regarding the reasonable value that it adds, and sort of cost-benefit analysis. And we've also heard from the voices of disability advocates, and just making sure that we are here to push for making sure that our health systems are safe and healthy for everybody. And that starts with making sure that they are safe and healthy for the most vulnerable, knowing that we are all potentially vulnerable to long COVID, especially every additional time that we become infected with COVID. Thanks again for joining us, and this recording will be available. It'll be shared with all attendees, as well as available on our website. Thank you so much for joining us.
Thank you so much, Lara. Okay, I'm going to pause the recording.